Thank you very much. I will just share the screen and I thank the organizers for inviting me for this wonderful conference and wonderful session. And I will be talking on the aspect of the role of NGS in lung cancer. And so as of now, whenever we encounter a metastatic lung cancer patient, we tend to look for major biomarkers, the EGFR, ALK, and ROS, and we are keen to get more and more information on other biomarkers like FET, MET, BRAF, and PDL1. So the major challenge what a clinician faces in their routine practice is as and when we go ahead with the sequential approach of biomarker analysis, the tissue gets exhausted. By the end of the fourth test, 50% of the times, the tissue is almost gone. The major challenge is the tissue, especially when we have very limited tissue because of these small biopsies, what we normally do during the cancer diagnosis. So the CAP as well as ESCO guidelines recommend all the biomarkers to be studied upfront for all the important genes, including the EGFR, BRAF, KRAS, HER2, MET, as well as ALK and ROS. And interestingly, we have to look for point mutations, copy number alterations, and rearrangement. So a test which can cover up all the important genes and all the important variants of alteration is something ideal for this case scenario. And the answer lies in the NGS, that is the next generation sequencing, which is basically gives answers to majority of the cases. And whenever we do NGS, we have options of amplicon-based assays or hybrid capture-based assays, which seems to be quite good to pick up the point mutations. But for copy number alterations and rearrangement, hybrid capture-based assays seems to be better. So in terms of single sequential biomarker approach, a conventional approach, we are not able to pick up that well. The positive predictive value is less. If we use the NGS approach, we may pick up 35% more ALK alterations as compared to the standard of care FISH, and 17% more EGFR cases as missed by the hotspot assays, current assays. This particular slide is showing that in up to 20% of the cases, NGS can pick up better EGFR mutation as compared to the standard of care ARMS PCR test. Similarly, 35% of the ALK can be picked up better as compared to FISH. Not only that it can do a better pickup rate, it has the importance of identifying what molecular partners is seen in the ALK fusions, whether it's EML4, KIFP5, which are the common one, and the rare TFG and KLC and PTNP. And also, even for the EML ALK4 alteration, there are various variants, and each variant have some significance in terms of predicting the response to the standard of care crizotinib. So this detailed information can be obtained by the NGS only. There is no other way to identify the partners and the variants by the standard of care FISH analysis. Also, the liquid biopsy, when the biopsy samples are not enough, or at the time of disease progression, liquid biopsy becomes very useful, and understanding the genomic signatures in the liquid biopsy is only possible with the help of next generation sequencing. Liquid biopsy can complement tissue-based profiling. It has a concordance of almost 2/3 times, and in 86% times, the liquid biopsy can pick up genetic alterations affecting more than one pathway. So you may end up having more options at the same time if you're not able to do a solid tumor biopsy and the analysis. So this is again based on the NGS data. NGS have shown to have clinical benefit in the real world practice, whether it is a tissue biopsy based NGS or liquid biopsy based NGS. And if you're able to pick up the relevant targets, the overall response rate is approximately more than 50% in across all the genomic alterations observed. So this is very, very important, and we are confident that yes, this approach seems to be a better approach as compared to the single sequential biomarker-based approach. New treatment options in non-small cell lung cancers is now driven by various genomic signatures beyond EGFR, ALK, and ROS. And we know the rare alterations like NTRK, alterations like HER2 new mutations or HER2 new amplification, RET alterations, MET alterations can give us a lot of treatment options if we are able to identify them. In routine clinical practice, we are not looking for these alterations, but yes, it is all feasible with the help of NGS. In this particular slide, I'm just showing that the MET exon 14 skipping mutation, which can be identified by the NGS, is a very good biomarker for the drugs like capmatinib. And you can see this waterfall plot with the maximum change in the tumor size. And you can see overall response rate in terms of 68%. So this is the beauty of this technology and the drugs available. And this can only be feasible with the help of NGS. Again, the drugs like tepotinib, similar to capmatinib, have a very important response rate, or you can say role, in treating the MET exon skipping alterations with the response rate in the range of 50%. Similarly, rare alterations like RET fusions, drugs which are the RET inhibitors like selpercatinib, again shows a very good response rate in the range of 64%. So the message here is rare alterations. If you are able to identify them, you may give a lot of treatment options or hope for the patient. Again, the perlasatinib, which is also a RET inhibitor, shows a significant response rate similar to the selpercatinib actually. So let's talk about the other information what you can identify with the help of NGS. NGS can also give you information on the concept of tumor mutation burden. In routine clinical practice, we look for PD-L1 as a biomarker, but there are certain scenarios up to 8% of the non-small lung cancer, which are negative with PD-L1 staining, show responses to immunotherapies, immune checkpoint inhibitors like pembrolizumab. So the biomarkers like TMB, which is now a tissue agnostic biomarker for response to immunotherapy, can only be calculated with the help of NGS. This subset analysis shows that patient with high TMB and low PD-L1 shows response durable clinical benefit with monotherapy as well as CR and PR with the PD-1 and CTLA-4 combination therapy in non-small lung cancer in up to 33-35% cases. That is 1/3 of the cases. So these subset of patients can only be identified with the help of NGS. We do not have any other technique beyond NGS to identify them. Similarly, the liquid biopsy is also a very robust way to do the NGS and understand the genomic alterations. Patients can be subject to liquid biopsy can give us information on the blood-based TMB. And this data set is showing that blood-based TMB is also a very good biomarker, where this popular and OAK study have shown that the blood-based TMB is more than 16, and they have received atezolizumab, shows a better PFS as well as OS benefit. Again, the blood TMB can be a tool for the response to durvalumab as a first-line setting shown in this MYSTIC phase 3 trial, but the cutoff here have been used as more than 20 mutations per megabase. Similarly, the TMB can also give you the benefit of predicting the response to immunotherapy plus minus chemotherapy. And this is basically giving the, and the cutoff for this is 16 mutations per megabase. with pembrolizumab. So durvalumab, atezolizumab, as well as pembrolizumab, all these three can be easily predicted, response can be predicted based on the blood TMB. So this is my own data set, which is not yet published, where we did NGS on a larger cohort of samples, almost 35, where we did the foundation medicine test, comprehensive genomic profiling. And you can see that besides the EGFR, ALK, ROS, MET, BRAF, creatinine, RBB2, which are reported as per the NCCN guideline, various other biomarkers which are not in the guidelines were also picked up, like BRCA2, CDK4, PDGFR beta, PDGFR alpha, and PTEN and STK as well. So if we talk about the actionability total, out of 35 cases analyzed, 34 were having some or the other form of actionability, whether in the form of TMB, whether in the form of the genomic alteration. If we just see the NCCN guidelines, out of 34 cases which showed alterations, 24 of them had alterations which were as per the NCCN guidelines, and 8 were additional, which can be considered to be tier 2 as per the ASCAT scale or investigational nature. But if I were to use only the sequential approach, that is EGFR, ALK, and ROS, I would have picked up only 16 cases as per this report, and that is the 46%. So the advantage of identifying alteration from 46% to 70%, even for the NCCN guidelines, and 97%, including the investigational drugs, is something very important, and we should look for it. If we compare the my data set with the internal analysis, what we did, the EGFR pickup rate of the standard of care testing showed 23%, as compared to the NGS platform showing 26%. In my analysis, ALK pickup rate was similar, but NGS was able to pick up ROS, MET, BRAF, RAT, ERBB2, and KRAS alterations. So to summarize, EGFR, ALK, ROS pickup rate was higher in NGS, approximately 45%, as compared to single platform analysis, 33%. So this is a case study where a 56-year-old gentleman who was diagnosed with metastatic non-small cell lung cancer had EGFR del19 mutation, was given erlotinib and afatinib, had progression. Investigate further, was found to have T790M. We are very happy that yes, we have the answer, but the patient was given osimertinib but had a quick progression. On investigation using the NGS with foundation, what we found that the patient have ERBB2 amplification. So this is one of the possible resistance mechanism to the above treatment given, along with the EGFR amplification, which can be a relative mechanism for resistance to the EGFR TKIs. So with that, I want to summarize that the standard molecular tests such as IHC, FISH, and the comprehensive genome profiling like NGS complement each other, and we should use the NGS to detect several biomarkers in once, which helps us to avoid the tissue exhaustion, and it saves a lot of time. So with that, I thank you all for your kind attention. Over to the organizers. I can take any questions if you have any.
Thank you, Dr. Verma. It's an excellent session and very comprehensive, informative on NGS. Particularly, it is quite obvious from your talk that more number of patients will be given targeted therapy if we use NGS upfront rather than going for a sequential testing of using PCR, FISH, etc. But your data showing 70% of patients showing some actionable alteration, it's really interesting. And definitely having a molecular oncologist in the institute will make a difference. Thank you so much for your time.
Thank you very much.
For giving second talk, we have